بسم الله الحمد لله والصلاة والسلام على نبينا محمد وعلى آله وصحبه وسلم. This is the last lecture regarding blood pharmacology and the course Pharmacology 1 or General Pharmacology. In the last lecture, we start talking about blood pharmacology and we talk about the anticoagulant drugs. We talk about heparin, injectable heparin and low molecular weight heparins, the injectable anticoagulant. Then we talk about oral anticoagulant الكومارينز اللي هو we talk about الوارفرين. We saw the mechanism of action and clinical uses and adverse effects. Now we will continue on blood pharmacology. Today inshallah we'll talk about the antiplatelet and fibrinolytic drugs. Aspirin in low doses, only in low doses, such as 75 milligram, 81 milligram, and 100 milligram. All of these concentration are available. Alters the balance between thromboxane A2, which promote aggregation, which secreted from platelet when activated, as we saw in the last lecture, and the prostaglandin I2 اللي هي البروستاcyclin which inhibit البلاتلت aggregation. البروستاcyclin secreted from endothelial wall. This why alter the balance, because it irreversibly inhibit thromboxane A2 production from the platelet, while the inhibition of prostacyclin will be reversible. This is why, because the platelets are anucleus, cannot replicate or cannot divide, while the endothelial wall can secrete. بعد ما يحصل لها inhibition below dose can secrete, this will be reversible, can secrete another a new prostacyclin, so this will be reversible. معناها البالانس هيختلف. نحن عندنا we have الثرومبوكسين A2 anticoagulant, عنده anticoagulant الثرومبوكسين A2 بيعمل coagulation while prostacyclin عنده anticoagulant effect. طيب لما نثبتهم الاثنين مع بعض البلد في بالانس بين الانتيكواجولانت افكت والكواجولانت افكت. لكن لما نوقف الثرومبوكسين A2 irreversibly ويبقى بعد ذاك الانهبيشن بتاع البروستاجلاندين I2 reversibly، معناه كان reactivate او كان new molecules or new prostaglandins that secreted by endothelium ترجع الاكتيفيتي بتاعتها اللي هي عندها anticoagulant effect، يبقى معناها البالانس اختل في اتجاه انه في anticoagulant effect نتيجه للاكشن بتاع البروستاcyclin. This is why in low doses. طيب if we use aspirin in higher doses such as 300 milligram, such as the commonly dose that used for treatment of pain or inflammation, such as rheumatic arthritis and other inflammatory disorders, here the balance will be in equilibrium, because this high dose can inhibit both thromboxane A2 from the platelet and can inhibit the prostacyclin from the endothelium. So the only aspirin only in small doses have the anticoagulant effect or has the antiplatelet effect. As I mentioned, this low dose reduces both thromboxane A2 synthesis in the platelets and the prostaglandin I2 synthesis from in the endothelium. Vascular endothelium cells, however, can synthesize new enzyme, whereas platelet cannot. So, as I mentioned, the effect on platelet will be irreversible, while the effect on the endothelial cell will be reversible. Aspirin After administration of aspirin, thromboxane A2 synthesis does not recover until the affected platelet replaced in 7 to 10 days. ودي اللي هي the lifespan. This is the lifespan of platelet. As you know that the platelet are synthesized from the bone marrow and circulate with the blood for 7 to 10 days, and this is a lifespan because they are anucleus, they cannot replicate, they cannot divide. So only this will depend on a new cells that release or synthesize from the bone marrow. Higher doses of aspirin are needed to inhibit cyclooxygenase in the vascular endothelium than in platelet, especially when administered orally, as I mentioned. Aspirin is used in the prophylactic treatment of transient cerebral ischemia to reduce the incidence of recurrent myocardial infarction and to decrease the mortality in the setting of primary and secondary prevention of myocardial infarction. We have another antiplatelet drug called dipyridamole. Dipyridamole is a coronary vasodilator that increases intracellular levels of cyclic AMP and cyclic GMP by inhibiting phosphodiesterase enzyme. And as you know that the phosphodiesterase enzyme is the enzyme that is responsible for the degradation of the cyclic AMP. It decreases thromboxane A2 synthesis due to the inhibition of the platelet activation by increasing the cyclic AMP. As we saw in the last lecture, this will lead to resting platelet, so antagonize the activation of the platelet and so antagonize the release of thromboxane A2. It potentiates the effect of procyclin to antagonize the platelet stickiness and therefore decreases platelet adhesion الالتصاق to the thrombogenic surfaces. Dipyridamole is used for stroke prevention and it's usually given in combination with aspirin because they have additive effect. Additive effect means 1 plus 1 equal to 2. They have additive effect. This is dipyridamole mainly act as vasodilator due to the inhibition of degradation of cyclic GMP resulting in vasodilatation. Also, it inhibits dipyridamole inhibits phosphodiesterase, so this will increase the cyclic AMP and this will lead to resting platelets. Patients with unstable angina should not use dipyridamole because of its vasodilating properties, which may worsen ischemia because this can lead to reflex tachycardia. Reflex tachycardia increase the heart work, and this will lead to maybe ischemia due to the deficiency of an oxygen supply in case of unstable angina and myocardial infarction. Dipyridamole commonly causes headache and can lead to orthostatic hypotension. This is two pharmacodynamic adverse effects related to the pharmacological action, especially if administered IV. Clopidogrel and tilcopitin, this is also a famous antiplatelet agents that act mainly by inhibiting ATP receptors. Their mechanism of action, they inhibit binding of ATP to its receptor. They block ATP receptors on the platelet. So thereby they inhibit the activation of glycoprotein 2B3A receptors that required for platelets to bind fibrinogen to each other. ما نحن شفنا we saw this type of receptors glycoprotein 2B3A which occur on the surface of the platelets and tend to bind platelets together through the fibrinogen. So by inhibition of this receptor, they will inhibit the platelet aggregation. The maximum inhibition of platelet aggregation is achieved in 3 to 4 days with tilcopitin and in 3 to 5 days with clopidogrel. This is a mechanism of action of tilcopitin and clopidogrel, which inhibit the binding of an ATP to its receptor, which can lead to the stimulation of the calcium release, which activate glycoprotein B2A, glycoprotein 2B3A receptors. The therapeutic uses of clopidogrel and tilcopirdine are the first. Clopidogrel is approved for prevention of atherosclerotic events in patients with a recent myocardial infarction and stroke, and in those with established peripheral arterial disease. It also approved for prophylaxis of thrombotic events in acute coronary syndromes such as stable angina or non-stable via ST elevation myocardial infarction. ST according to ECG elevation في segment ST segment elevated in some types of myocardial infarction, as you know. We have another group of drugs which are called glycoprotein 2B3A receptor antagonists. They are directly antagonize these receptors such as abiximab. Antagonists of glycoprotein 2B3A receptors have the theoretical attraction that they inhibit all pathways of platelet activation, because the main result from the activation of platelet is to aggregate together and bind together through this fibrinogen with glycoprotein 2B3A receptors, then fibrinogen converted to the fibrin اللي هو insoluble. As or since these all converge on activation of glycoprotein 2B3A receptor، لأنه كل الاكتيفيشن إذا كان through ال ATP أو through ال 5-hydroxytryptamine or through a thromboxane A2 tend to activate the aim is to activate this type of receptor to stimulate the platelet aggregation. Antagonists of glycoprotein 2B3A receptors include monoclonal antibody اللي هو الابيكسيماب and several oligopeptides such as التيروفيبان. The therapeutic uses of this type of drugs, this group of drugs, these agents are given intravenously along with heparin and aspirin as an adjunct to percutaneous coronary intervention for the prevention of cardiac ischemic complication. نديهم as adjunct للpercutaneous coronary intervention اللي هو through the catheterization, as you know, for prevention of cardiac ischemic complication. Abiximab is also approved for patients with unstable angina not responding to conventional medical therapy when percutaneous coronary intervention is planned within 24 hours. إذا مخططين ندي المريض أو نعمل له BCI, before the BCI we can administer this type of or this group of drugs for prevention of to prevent the coagulation that before the planned BCI is done. Last, we have the fibrinolytic drugs. As we saw in the previous lecture, after the fibrin clot is formed, insoluble clot formed, this can be removed or cleavaged or break down by the plasmine. So a fibrinolytic drug directly stimulates the plasminogen to plasmin, which tend to lyse or degrade the fibrin clot. These drugs include ureakinase, streptokinase, and the last one called alteplase. The enzymes, all of these enzymes stimulate directly plasminogen to plasmin, which lead to lysis of the fibrin clot. Acute thromboembolic disease in selected patients may be treated by administration of agents that activate the conversion of plasminogen to plasmin. This is a just mentioned drugs اللي هي fibrinolytic drugs and these drugs are serine protease that hydrolyzes fibrin and thus dissolve clots. اللي هو البلازمين هو serine protease that hydrolyze fibrin and thus result in dissolution or dissolve the clots. This agent alteplase, streptokinase, urokinase, which tend to stimulate البلازمينوجين to plasmin, which convert the fibrin to degrade the fibrin, result in fibrin degradation products. First, we have streptokinase. It is a protein that extracted from the cultures of streptococci. عشان كده اسمه strepto جاي من streptococci species, bacterial species. It activates, as we mentioned, it activates the plasminogen. If infused بنديه بشكل بتاع infusion, infused intravenously, it reduces mortality in acute myocardial infarction, and this beneficial effect is additive to aspirin. These effects of streptokinase who are additive to the effect of aspirin. Its action is blocked by anti-streptococcal antibodies because it is a bacterial product. So if the body sensitizes antibody for this streptokinase, this will lead to the blockage of these effects, which appear usually after 4 days or more after the initial dose. So at least 1 year must be elapsed before it is used again. إذا ما ادينا مريض الستريبتوكاينيز لأنه متأكدين تماما بعد 4 أيام الجسم بيكون صنع له antibodies فور الستريبتوكاينيز وطوال حيكسر الاكشن بتاعه. الانتيبوديز دي في الجسم تقريبا داير لها 1 year to be cleared عشان ما تختفي، وتاني بعد ذاك ممكن ندي المريض ستريبتوكاينيز يقدر يستفيد منه، لانه اذا ادينا له within this year حيكون لسه ستيل عنده انتيبودي في الجسم بتاعه، وبالتالي ما حيقدر يستفيد من الدواء بتاعنا اللي هو الستريبتوكاينيز، لانه الانتيبوديز دي directly will neutralize الستريبتوكاينيز. Alteplase and urokinase, because of their short half-lives, they must be given intravenous in the form of intravenous infusion. Urokinase is produced naturally in human kidneys and directly converts plasminogen to active plasmin. Therapeutic urokinase is isolated from the cultures of human kidney cells and has low antigenicity. Because we have the first one, the streptokinase, is famous with its antigenicity. Alteplase may cause orolingual angioedema and thereby may be increased by the risk of the risk of this effect when combined with angiotensin converting enzyme inhibitor. لأنه as we mentioned before, angiotensin converting enzyme inhibitors as a side effects هي برضه بتعمل angioedema. So if they are combined إذا كان بيتاخدوا at the same time في at the same patient في نفس المريض, this will increase the risk of angioedema. Here we have a comparison between these 3 fibrinolytic drugs. First, regarding antigenicity, we have the streptokinase, the more or have higher antigenicity. This is because while urokinase and alteplase have lower antigenicity because they are urokinase, they are natural occurring, especially urokinase, as we mentioned before, to occur within the kidney cells, but the streptokinase is famous with its antigenicity. Regarding the fibrin specificity, we will find that both alteplase and urokinase had a high or have high specificity, while this is a comparison between the half-life time of these 3 fibrinolytic agents. يمكن the most or the more long acting is the streptokinase, which is more than 20 minutes. Now we'll talk about the fibrinolytic contraindication. These 3 drugs are contraindicated in the following condition. First, in pregnancy. Also, they are contraindicated in patients with healing wounds. Also, the history of cerebrovascular accident is a contraindication for fibrinolytic drugs, brain tumor and head trauma and intracranial bleeding. Also, this is a contraindication. And last, metastatic cancer. Also, patient with metastatic cancer, fibrinolytic drugs are contraindicated for this patient. Also, patient with uncontrolled hypertension. These drugs are contraindicated for patients also with uncontrolled hypertension. Fibrinolytic unwanted effect. The first side effect will come to your mind directly is the bleeding, the risk of bleeding, the risk of hemorrhage, especially in patients with wound healing. This, for example, here we have untreated patient. The patient مريض عندنا which have this patient have hemostatic bulk، كان عنده bleeding وده حصل hemostatic bulk. الحقيقة العملية الفسيولوجيكال بروسيس الطبيعية انه يحصل bulk او يحصل كلوت نتيجة للانجري physical injury within the capillary or within the blood vessels. في نفس الوقت المريض ده كان عنده thrombus, pathological thrombus. If we give this patient treated with plasminogen activator such as streptokinase or ureokinase, this will lead to directly removal of this fibrin clot within the hemostatic bulk and fibrin clot within the thrombus اللي هي الابنورمال او pathological thrombus. So this will lead to bleeding. So if you in the previous slide we mentioned that they are contraindicated in patients with wound healing because this will lead to bleeding, because this will resolve or will dissolve the normal hemostatic bulk that occurred to stop bleeding, will be lysis and lead to bleeding. As I mentioned, the main hazard of all fibrinolytic agents is bleeding, this including gastrointestinal hemorrhage and stroke. If there is a serious bleeding that occur due to the use of fibrinolytic agents, we can treat this with a drug called tranexamic acid or fresh plasma or coagulation factors, infusion with coagulation factors. Streptokinase can cause allergic reaction because as we mentioned, it has high antigenicity, so this can lead to allergic reaction. Streptokinase also can cause hypotension. Last, we will talk about the drugs that are used for treatment of bleeding. This is the last topic here in our course. Bleeding problems may have their origin in naturally occurring pathological conditions such as hemophilia. As you know, because of hemophilia A or hemophilia B, there is a defect in certain types of clotting factors, or as a result of fibrinolytic states that may arise after gastrointestinal surgery or prostatectomy. The use of anticoagulants may also give rise to hemorrhage. Certain natural proteins and vitamin K as well as synthetic antagonists are effective in controlling this bleeding. Concentrated preparation of coagulation factors are available from human donors, ودي ممكن نديها للبيشن عندهم this type of bleeding. We have aminocaproic acid and tranexamic acid. These two drugs are used for treatment of bleeding. Now we'll see their mechanism of action. Fibrinolytic states can be controlled by the administration of aminocaproic acid and tranexamic acid. Both agents are synthetic, orally active, excreted in the urine, and inhibit the plasminogen activation. They act by inhibiting the plasminogen activation because we know that the plasminogen activation will lead to plasmin, which lead to the lysis of fibrin. Tranexamic acid is 10 times more potent than aminocarboic acid. A potential side effects of tranexamic acid is intravascular thrombosis. يحصل لي intravascular thrombosis. عكس تماما كل الانتي بليتلت انتي كواجولانت and fibrinolytic السايد افكت بتاعتها ممكن تعمل لي بليدنج. عكس منهم هم الامينو كاربويك اسيد and الترانزاميك اسيد السايد افكت بتاعهم انهم ممكن يحصل intravascular thrombosis لانه بيعمل انهبيشن لللايسيس بتاع الفبرين عن طريق انه يعمل انهبيشن للاكتيفيشن بتاع البلازمينوجين تو بلازمين. We have also the protamine sulfate. As we mentioned in the last lecture, protamine sulfate is the antidote of heparin. Protamine sulfate antagonizes the anticoagulant effects of heparin. This protein is derived from fish sperm or testes. We obtain the protamine sulfate from the fish sperm. The positively charged protamine interact with the negatively charged heparin as we mentioned before, forming a stable complex without anticoagulant activity, leading to neutralization, one-to-one neutralization of heparin molecules. Adverse effects of protamine sulfate include hypersensitivity as well as dyspnea, shortness of breath, flushing, bradycardia, hypotension, بالذات especially or hypotension when rapidly injected. إذا ادينا البروتامين سلفيت in a rapid bolus injection, this can result in hypotension. Also we have vitamin K, which can be used for treatment of bleeding, especially that bleeding result from overdose of warfarin, because vitamin K is the antidote of warfarin, as we talked about in the last lecture. Vitamin K1 اللي هو الفيتوناديون administration can stop bleeding problems due to warfarin by increasing the supply of active vitamin K1, thereby inhibiting the effect of warfarin, because we know that warfarin competitively antagonize vitamin K, the formation of reduced form of vitamin K. So in case of increased the level of vitamin K, so we can overcome the warfarin effect. Vitamin K1 may be administered via oral, subcutaneous, or IV routes. IV vitamin K should be administered by slow IV infusion to minimize the risk of hypersensitivity or anaphylactoid reactions. The response to vitamin K is slow, requiring about 24 hours. This is the time to synthesize new coagulation factor. Thus, if immediate hemostasis is required, fresh frozen plasma should be infused للمريض إذا كان دايرين immediate response. Last, we have this picture from Pharmacology, Rang and Dale Pharmacology reference. We can summarize the drugs that affect the blood pharmacology from this picture. First, we talk about the anticoagulant drugs, and we mention the heparin and low molecular weight heparins, which act through inhibition of antithrombin 3. We have also heridine, which is a direct thrombin inhibitor. Warfarin, which act by inhibiting or interfering with the vitamin K, oral anticoagulant. The first one are injectable anticoagulant, while warfarin is the oral anticoagulant. All of these drugs tend to inhibit the activation of the clotting factors, تحديدا اللي هو الثرومبين, البروثرومبين to thrombin, to prevent the fibrin, to prevent the formation of fibrin اللي هي insoluble clot. Then we talk about antiplatelet agents, which all of antiplatelet agents tend to inhibit platelet activation, such as aspirin through the inhibition of the formation بتاع synthesis بتاع ثرومبوكسين A2 from the platelet, الدايبيريدامول through inhibition of the phosphodiesterase enzyme leading to inhibition of inhibition of intracellular calcium, so inhibition of activation of platelet. الكلوبيدوجريل and كلوبيدين which inhibit الادينوزين او الADP receptors, and also الابيكسيماب which inhibit الجلايكوبروتين 2B3A receptors. All are can be considered as antiplatelet agents. Then we talked about الفيبرينوليتيك agents اللي هم الالتيبليز والستريبتوكاينيز واليوريكاينيز which activate الفورميشن او الكونفرشن بتاع البلازمينوجين to البلازمين which lead to the lysis of الفبرين or increase او lead to fibrin degradation to a products, بالتالي يكسر لي insoluble fibrin clot. Last, as I mentioned, all of these drugs, anticoagulant, antiplatelet, or fibrinolytic drugs can result in a bleeding as side effect, can lead to bleeding as side effect, and this bleeding can be treated by agents such as the antifibrinolytic agents such as the tranexamic acid, if this result, especially if this result from fibrinolytic agents, or can be treated by alburetamine sulfate, especially if the bleeding arise from the heparin use, or can be treated by vitamin K if this is occurred due to the excess or excessive warfarin dose. I think that is all. Assalamu alaikum wa rahmatullah wa barakatuh. We have some study questions. 58-year-old man received his intravenous alteplase treatment for acute stroke, fibrinolytic. 5 minutes following completion of alteplase infusion, he develops orolingual angioedema. Which of the following drugs may have increased the risk of developing orolingual angioedema in this patient? Is it ACE inhibitors, glycoprotein 2B3A receptor antagonists, phosphodiesterase inhibitors, thiazide diuretics? Definitely here ACE inhibitors, which is famous with the angioedema. A 62-year-old male taking warfarin for stroke prevention in atrial fibrillation present to his primary care physician with bleeding. أكيد this bleeding due to warfarin. He is instructed to hold his warfarin dose and given طبعا أكيد أول advice, the first advice to hold يعني to stop الwarfarin dose and given 2.5 milligram of oral vitamin K1. When would the effects of vitamin K most likely to be noted in this patient؟ يعني effect بتاع الفيتامين K هيبدأ يظهر بتين في المريض بتاعنا. Is it after 1 hour or 6 hours or 24 hours or 72 hours? Definitely, as we mentioned before, the vitamin K effect will be appear after 24 hours. Last, which is most appropriate for reversing the anticoagulant effects of heparin؟ وطبعا دي straight forward اللي هو هيكون البروتامين سلفيت هو the appropriate for to reverse عشان ما يعكس الاكشن بتاع الهيبرين. That is all. السلام عليكم ورحمة الله وبركاته.